will be clot formation in that pelvic ileal system.
Yes.
And now the fluid will also not come very free.
Yes.
So don't immediately lose your and then withdraw and do
that
it.
is another reason to change the calyx. Because if you are going to the same calyx which you have punctured, and if there are clots inside that calyx, you will get blood again and again. The same puncture on the same line.
So regarding puncture, so we move ahead. Regarding puncture, I have two questions for my panelists. Does the selection of the calyx really matter? Like do you really think whether I'm going to do a lower, upper or mid calyx puncture? There are people known to me always take upper calyx puncture because they feel that coming from the roof you can see the whole house, like you can see all the calyxes. And there are people who are doing only mid calyx puncture, and there are people who will select the calyx according to the stone load. And do you really care for a papillary puncture? Like you are not, whether are you bothered about a papillary or a non-papillary puncture? So, Pal sir?
Only papillary punctures.
Okay, and
no selection or bias about any calyx.
Okay, Prashant?
Whatever stone demands.
Yes, Prashant?
Only papillary puncture to be tried. I'll try half hour, 1 hour to get a proper papillary puncture. That's number one.
Yeah.
And number two, the selection of calyx, no. Any calyx, upper, lower, middle, what that particular case demands. If you are sure about the calyx something, why do you imaging preoperatively then?
Okay. So, Nitish?
Same thing.
So the point here is, Prashant, a prefixed idea of where you are going to take a puncture. Whether you always like lower or you always like mid, or you are a fan of upper calyx.
I'll see the imaging. I'll see the imaging before I go in the theater,
so
and
that,
then I'll make up my mind.
Yes. So, Nitish?
Always a papillary puncture.
Okay.
In supine, I avoid the polar calyxes, the lowermost lower calyx and the uppermost upper calyx. These two are very difficult to puncture and also very difficult to manipulate with.
Okay.
So,
Sure.
Sir, I think more than selecting the calyx, it should be the line of puncture. It should be straight from the skin to the parenchyma to. So where the maximum stone get clear in that direction, I think I will select that calyx to the puncture.
So if you see
At any stage of maturity, you should have two calyxes in mind.
Yes.
Not that 100% you will get the calyx which you have chosen.
Yes.
So you should always have a plan B in mind. If doesn't successful, then second.
Okay. So if you see the literature which has studied the pattern of calyxal puncture, and these are large studies. So usually people say that in upper calyx the tract is long and the trajectory is more. But there are papers who say that in lower calyx also the tract is longer and it's a oblique tract, you know. But the basis, you have to understand that your calyx should be shortest possible from the skin, and you should avoid oblique tracts, because if you have an oblique tract, then definitely you are traversing more parenchyma and there are high chances that you injure the blood vessels. Regarding papillary and non-papillary puncture, absolutely my panelists are to the point that you have to take papillary puncture. There is no question that you should go away from the papilla or take a non-papillary puncture. And also remember the vasculature, especially the arterial vasculature, is dense around the upper calyx. If you are taking upper calyx or if you are compelled to take upper calyx, you have to be very, very careful, because these are the punctures which can lead to bleeding. So once I get a successful puncture, I dilate the tract, and once I remove the dilator, this is a 22 French dilatation, I've removed the dilators, and from the ampullars, this is the bleeding. So what will you do, Pulsar, next?
This is a dark venous blood. So I will just pack with the long gauze piece and go for a coffee.
Okay, sir.
After 10 minutes, I will have a look once again.
So it doesn't stop, sir, it is bleeding the same way. What will you do?
So by the time sir finishes his coffee, I'll be in the theater. I'll put in a scope, let the water in. Probably the clots will come out, and then I will see if there is any bleeding.
Okay.
Many times there will be no bleeding.
So you will put in a nephroscope and inspect.
Yeah, I'll
the system,
put in
you
a
will not
nephroscope.
do anything. So Kama sir, what will you do?
Yeah, when he is washing, I'll ask my assistant to wash from below also.
Okay, so you want to see whether it clears from. So it is not clearing. And this will not clear. So if you see the bleeding.
I know.
Yes, sir.
But
So what will you do?
take-
What will you do next?
Take off all the clots, go into the nephroscope,
Go into the nephroscope.
and reposition your nephrostomy
Okay,
access.
fine. Yes, sir. Nitesh?
I will go in and look at the site of the bleeding. Mostly it occurs when we are under dilated, the ampullus, see it is not through to the PCS system. You just move in advance, and most of the time you will get a clear.
Yes, Kishore, any difference of opinion?
No, I'll just keep a nephrostomy, clamp the nephrostomy.
Okay, so Kishore wants to stop the procedure here. So this is what, as other panelists said, we tried to put in a nephroscope. This was the picture as soon as we put the nephroscope. So it was continuously bleeding, but if you see carefully, there's some underdilatation. You can see a part of the calyx on the right side of your screen. So what we did is, we advanced the ampullate sheet gently. So advancement also should be gentle. Don't force the ampullate sheet, because again you will damage the calaceal mucosa. Just rotate it gently on the nephroscope or under vision, whatever you can do, and the bleeding immediately stopped. So we continued the procedure and stone lithotripsy was.
I would like to add a point here.
Yes, sir.
As you advance, I would rather do it with a pilot. I'll put a pilot and then advance it.
Pilot.
Otherwise, the pilot rod.
Oh, the guide rod.
Yes,
Guide rod.
Yeah.
So you want to advance over the guide rod.
Yeah.
Okay, sir. So what the reason?
The idea is the guide wire sometimes bends. You may not be able to.
So this is another case. We were doing mini-per with a 17 French sheath, and as soon as the scope was put, this was a 12 French mini-per. It was continuously oozing from the tract. The puncture, the dilatation was absolutely fine. There was not a single drop of blood. We also tried to advance the ampullate sheath as suggested by many of our panelists, but the bleeding was just not stopping. So, Pal sir, what will you do?
That is the reason when there is a venous oozing, there is nothing is lost by waiting for 5 minutes.
So there is an arterial.
If you immediately bend upon and immediately put the nephroscope and start muggling with there, it will continue to bleed like this.
Yes. So in this case, you can see a arterial spurter on the left side of the screen. If you observe the, I'll just rerun the video, sir.
All of us are very familiar with the open surgery. Many times you just keep it pressed for 5 minutes, 7 minutes, then you are in a cool state of mind. Oozing is not that much, and you can very well manage the
So
case.
compression also works in endoscopic
dilatations. If you stop the irrigation and then see if it is really torrential.
See, there is a bleeder.
Then
You can see a spurter on the left side of the screen. So Prashant, what will you do?
Usually in such situation, this is a metallic mini-per
Yes,
sheet. So I'll prefer not to use metallic.
Yeah, but we
mini-per
have
sheet.
used now. What?
No. If I get a bleeding like this, I just take out that sheet. I put in my plastic ampullate sheet, because that has a tongue.
Achha, you will change the ampullate sheet.
Yes, that has a tongue.
But
That
it
will
is
compress
not
the.
served that, it is continuous.
Then wait for his coffee to finish. He will come.
Okay. So
time will.
I think I would do the same. I'll just reposition the ampullates, wait for some time, because that doesn't look to be a very vigorous, large arterial bleed.
Okay, so stop for some time.
Yeah.
But it was not stopping. Like we did that, but the bleeding was continuous. Nitesh?
If even after sir finishes his coffee and nothing is there,
So we'll
looks
move
like
beyond the coffee now.
looks like a small stone, and for me that much vision is enough, and if I can complete the stone in 10 minutes.
But there is no vision. If you see the video, Nitesh, there is absolutely no vision. You can't see the stone anywhere properly. It is very difficult to do lithotripsy with such bad vision.
Why not to stage the procedure? So PCNL has that good idea and that get back
Yeah. So we were.
stop at any time.
I agree. Yes. So stage the procedure is the way. So I also was planning to stage the procedure, but my anesthetist wife said.
I beg to differ with Prashant, whether you hit with a knife or with a wood. If there is a bleeding, there is a bleeding. So changing from metal to plastic implants,
Nothing.
no difference. It is an injury. It is bleeding.
Yeah, so we were doing mini-per, laser was ready, so my wife said, why don't you just coagulate this with laser? So I just took the laser fiber, and there was only one single spurter. If you have observed the video carefully, we just laced thulium fiber laser, just stopped the bleeding there, advanced the ampullate sheet till the stone, just see the vision now. So you are confident to do stone lithotripsy, whatever you are using with the laser.
But everybody doesn't have a wife as brilliant as your wife.
For the benefit of the resident and juniors, I think anything happened to the PCNL where you are not comfortable progressing ahead.
So better to stop. Yeah. So at the point well taken, there's no problem. Pankaj, you have a question, comment?
Sir, this
Waiting will work only in venous bleeding. It will not work in arterial bleeding. But the moment he shows an arterial bleeder, how will waiting or putting a nephrostomy tube help? We are definitely not tamponading the system because the nephrostomy you put is much smaller than the tract you make. So with this arterial bleeding, I think there is no choice but to coagulate either by cautery or laser if you find a pinpoint bleeder.
Okay, thank you. So my next question to the panelists is, does miniaturization help or are you happy with standard PCNL? Pal sir?
Definitely it helps.
Prashant?
100% helps.
Kama sir? So everyone is for, and this is the literature, it definitely helps. So the take home message is, try to be, use the smallest possible scope for nephroscope. I think I'll skip this case. How much time I have? Is up? Okay. You're giving me 2 minutes. Okay. So this is a small case which was shared by Dr. Sanjay Deshpande. They tried to do a complete stag-on with PCNL. There was bleeding, so the case was abandoned. Only 30% of the stone load was removed. Second stage PCNL was done after 3 days, which was uneventful. But the procedure was stopped after 2 to 2.5 hours because it was taking a long time for the last stag-on to come out. And there was some residual upper polar stone which was there to be tackled later. Patient came after 8 days with severe hematuria, tachycardia, hypotension. Clot evacuation was done twice, but and after that the patient settled. Then he was hemodynamically stable. So, Pastor, what will you do next?
This is a secondary hemorrhage, and if the CVS instability is not there, cardiovascular system is stable, and he requires only 1 unit of blood every day, I will wait for 3 days. Unless the BP starts falling and tachycardia rises, then I will send him for angioembolization.
Okay, Prashant. So twice bled,
Yeah.
2 times clot evacuation.
He bled twice, you didn't get to a clot evacuation twice, there's tachycardia, hypotension. I'll at least do a CT angio, at least in my center, because getting a renal angio is not
Point
so
well
easy for
taken.
me.
Kamal sir?
Yeah, in addition to what Prashant said, I will send a sample for blood culture and urine culture also.
Okay. Nitesh?
Sir, after 2 episodes of clot evacuation, I will straight.
So you agree with angio?
Angioembolization.
So the angiography was done, renal angiography. There's a residual stone, and you can see a pseudoaneurysm there. So a coil was placed, the bleeding stopped, and the patient was absolutely fine. So what is a correct puncture? Correct puncture is through the papilla, and the trajectory of the tract should be within the 20 degrees of the frontal plane of the kidney. So this is the area where the broadest line lies. If you are within 20 degrees, you will definitely avoid bleeding in PCNL. Okay? So I think we'll skip this role of tranexamic acid because now level 1 evidence that it helps. So my take-home message is respect the stone. If it is a partial stone, stag-on stone, complete stone, multiple stones, always respect the stone which is in front of you. Respect the kidney. If it is a non-dilated system, the parenchyma is thick, anatomy is abnormal, like slightly malrotated kidney, horseshoe kidneys, respect the anatomy. And don't be overconfident, especially in difficult patient, difficult stone and difficult situations. Thank you very much. Thank you panelists. Thank you.
I apologize for my late entry.
Thank you.
So one point